morning, everybody. My name's Tom Skelton. I'm the CEO of Surescripts, and we're certainly happy to be here this morning. Very excited about the fact that HIMSS has given us this opportunity to chat with you about price transparency. As a reminder to the audience, as we go through today's session, please feel free to jot down some notes, et cetera, to get ready for questions. There'll be a Q&A time permitting at the end of the session. I'm excited to be joined here today by Drs. Troyen Brennan and Steve Miller, certainly two folks that are having a major impact on healthcare here in the U.S. and have a lot to say about the topic we're going to cover today. I've personally been doing this a long time, over 35 years at this point, and I think that the amount of progress that we have made around information management within healthcare is absolutely stunning. I'd also say that we still have an extraordinarily long way to go. There's just so much more that needs to be done and that can be done to make sure that the citizens of the U.S. get the care that they deserve at the prices that we're able to best provide it at. We all know that even with the progress that we've made, we've still got to continue to plow ahead. To get this started today, let me kick it off by just sharing a little bit of information to put things in context. What we're talking about is primarily price transparency, but there are a lot of different facets to this and a lot of angles there. One of the key things that we want to make sure gets highlighted today is the need to help increase the adherence to the treatment regimens that are being prescribed by physicians like our guests today. 40% of patients that choose to abandon treatment do so because of additional work, administrative work, that is associated with the script that they just received. 10% choose to abandon it because of the fact that there's an economic element to it that they just, quite frankly, can't deal with. And this issue of adherence is costing the U.S. healthcare system somewhere in the neighborhood of $300 billion a year. So what we're chasing here is a pretty big nut and something that I think can make a huge difference across healthcare. So with that, I'm going to sit down, join our panelists here, and get the discussion started. Guys, good morning. How are we all doing?
Good. Great, good.
Good. So we've known each other a while, so we don't need to do any real big introductions here this morning, but certainly in my time in healthcare, seen a huge amount of progress, as I just alluded to, and as CEO of Surescripts, there's no doubt that we get an opportunity to work across the healthcare system, right? If you look at the Network Alliance and the folks that comprise it, we've got payers and we've got pharmacies and we've got the health systems, the EHR vendors. There's a huge swath of the healthcare system that we're touching each and every day and partnering with to move ahead. We also understand that there are a lot of drivers that are leading us to take on this challenge of price transparency that relates to the friction and the adherence, et cetera, right? We've got the consumer aspect of this, which is something that we all encounter each and every day. There are a lot of patients out there that have chronic disease that are continually coming back to us looking for help, trying to make sure that we have the right information there. We're also seeing an unprecedented level of regulatory activity, right? The federal government is heavily engaged, the state governments are heavily engaged. So there's a lot going on there. In addition to that, and you guys know this firsthand, there are a lot of changes in the market itself in terms of who is providing care and what the players within the healthcare system do. Your own organizations are part of a major wave of consolidation in the space. So what I'd like to try and do to kick us off after you have a chance to introduce yourselves is to travel down that path a little bit, talk about the market, some of the dynamics that you and your organizations are responding to, and also talk a little bit about how the new organizations, the Cigna organization with Express Scripts as part of it, and certainly the CVS Health organization with Aetna now joining the family, intend to make a difference. So as we do this, we'll cover it really in four different aspects. We've got the market activity that we'll start off with. Then we're going to talk about the consumer angle. Then we'll delve into the price transparency piece, and we'll wrap up by chatting a bit about the vision for the healthcare system going forward. So with that, I'm going to start turning it over to you guys. Steve, bad news for you. We flipped a coin, and Jennifer called it. She did not call it in a way that allowed you to win. So, as Troy pointed out in the prep room, Troy felt that the gentleman who roots for the team that most recently won the Super Bowl should be able to go first. Steve didn't really care for that one because that meant Troy got the first 6 questions, and that really wasn't fair. So as a result, we're just going to stick to one here. But Troy, if you don't mind, could you do just a brief introduction of yourself, kind of give the audience a sense of your background and what got you to where you are at CVS?
Well, Belichick, when he wins the coin flip, he usually lets the other team go first.
So you're going to defer.
No, my background is fairly straightforward. I was in academic medicine up in Boston for about the first 20 years of my career, and then I went over to Aetna for about 3 years as the chief medical officer there, and then I came over to CVS about 10 years ago, and now welcoming Aetna, as you said, back into the family. So been relatively long period of time, but relatively a few short stops.
Great. Steve?
Yes, so thanks for having me, Tom. So I, like Troy, came out of academics. I'm a transplant kidney doctor by training. Went into administration, became the vice president of Washington University and Barnes Jewish Hospital, becoming increasingly evil over time. So to the pharmacy benefits manager. So I was the chief medical officer for Express Scripts. And then in one of the first mistakes that Cigna would make, and they'll probably make others in the future, they made me the chief medical officer for Cigna. So very few jobs, but progressively becoming more evil.
Noted. So why don't we jump ahead? Let's talk a little bit about the organization. Steve, obviously a lot of things going on in the market. Can you give the audience some context about what Cigna sees, what led to the Express Scripts relationship, and how that's going to change things going forward?
Yeah, so you all are very aware the market's really, really dynamic right now. But let's be very frank, pharmacy is the gateway for most patients. If you think about it, most patients will go to a hospital less than once a year. They'll go to a doctor less than twice a year. But the average person uses pharmacy 12 times a year. And if we can take pharmacy and make it a front door where patients every time we touch a patient, it's an opportunity to educate that patient, to get that patient engaged, and to get them really involved in their own health, we can do really great things. And at Express Scripts, we're able to do that. And now with Cigna, we're doing it for even more people. And so Cigna really wanted to have a leading PBM, those touch points. And when you think about it, just similar to Troy, the touch is extraordinary. Express Scripts had about 80 million lives. CVS touches about 20 million lives directly, but about 40 million lives indirectly. And then we have another company, Evacor, that touches almost 100 million lives. We have almost somewhere around 150 million unique lives we get to touch. And similar to Troy, if you can actually make this platform really work for patients and for the provider community, you can probably drive down costs, improve care, truly achieve the triple aim. And so that's the vision of this, is to really make it so healthcare is more accessible, it's less expensive, and it's higher quality than where we are today.
Fabulous. Thanks, Steve. Troy, how about the CVS Aetna side?
I mean, basically pretty much the same deal. I mean, I think that the only difference between our two organizations now is obviously the sort of retail pharmacy, and we're trying to sort of take advantage of that as opportunity to be able to sort of reach patients on a face-to-face basis. But it's the same thing in terms of sort of a lot of people are introduced and spend a lot of their time in the healthcare system with regard to pharmacy, and so we think it's a great place to be able to sort of build on in terms of coming up with new ways to control population health costs. So I think it's very similar to what Steve had to say.
So from our standpoint, if we look at it, to summarize, I guess, we've got a situation where it's a pretty dynamic market. We're seeing pharmacy as that front door, a nice way to help patients navigate a very complex healthcare system. I think it is an exciting time. There are tremendous amounts of change going on, lots of experimentation, lots of innovation in the market. And I think for our audience members, they can expect to see that really almost no matter the scale of the business, just a tremendous amount of new initiatives seeking to improve consumer engagement and get them what they need out of the healthcare system. Is that all fair?
Yeah, no, I think, Tom, the other point you got to remember is, and especially for this audience, drugs are becoming more important in the armamentarium. You know, when I was young, the second most common surgery early in my career was vagotomy and pyloroplasty for peptic ulcer disease. We do so few of those surgeries now, we can't even train a house officer on how to do them. The reality is H2 blockers and PPIs really work. They've revolutionized how we care for those patients. And when you look at the next generation of drugs that are coming along, we're talking about no longer need for surgery with cancer. We're treating cancer with immunologic agents. And so for you all, getting pharmacy right in your applications or in your EMRs is going to be crucial, because more and more patients are going to be relying on pharmacy as a therapeutic option versus traditional surgery or other things. And so the importance that our companies hopefully will play in the ecosystem just keeps going up.
Troy, anything else you'd like to add?
Well, I think Steve's exactly right, and there's a lot of there's a lot of exciting new technology in medicine, and then there's obviously a lot of new technology in terms of sort of connecting up the bits of information that exist in the healthcare system and ways in which we can use those to try to intervene on individuals. But in another way, it's basic sort of blocking and tackling. We just opened up, or we just had publicity about, we opened them a few months ago, about our new hub stores that are down in Houston. And they're an effort to sort of put more healthcare services in the stores. But the thing is, I find, the most striking thing I find from it so far is that when we have people who sort of come up to, with a sort of the genius bar there and talk to the sort of coordinator for the store and get their blood pressure taken, about 40 to 50% of the people have high blood pressure. Oh. And, 80% of them are basically sort of undiagnosed. Another thing that we've done is just, try to make public space available there so that, we can undertake things like, simple things like DPP classes to try to prevent the development of diabetes. So, there's a lot of excitement about the sort of new things we can do, and always excitement in the hospitals about sort of new technology that can be brought to bear. And obviously at the meeting like this, a lot of talk about technology and new efforts, but a lot of it's got to be aimed at basic blocking and tackling. The basic blocking and tackling that's preventive care, public health care, what we consider to be sort of relatively low-level primary care is just not getting done in this country. And those are probably the places where we make the biggest interventions. Like Steve said, generic medications have basically sort of eliminated a substantial disease. And that's the kind of thing that I think we're most focused on. Generic medication is a big part of that basic blocking and tackling.
Great. So let's move on. We've talked a little bit leaning in towards the consumer side, the access side. Let's continue down that thread. So turn now to the patient side of this. Obviously, every one of us in the room is a consumer of healthcare today. We may not be a patient necessarily at the moment, but we are certainly consumers of it. There's no doubt that consumers are looking for and demanding a different type of experience. We're all walking around today carrying our cell phones. We're changing the way we interact with every other portion of the economy. Those experiences are impacting how we view and what we expect from the healthcare system. I'll give the audience an example, but before I do that, let's ask the audience a quick question here. How many of you in the last week have done some type of shopping online, either made a purchase or just done comparison shopping to look at different alternatives, by show of hands? Right, and this is what's coming to healthcare, right? It is that type of behavior that is now spilling aggressively into the healthcare system. I have a family member that was diagnosed with dry eye syndrome. She's elderly. She goes to see her primary care doctor, someone that she knows, someone that she loves, has trusted for years. She gets the script, she shows up at the pharmacy, and in her eyes, that little tube is the equivalent of her mortgage payment for all those years she was trying to pay off the house. And in a modestly profane way, she expresses that and says, I'm not going to do this. That's not going to happen. And so now she's into what we politely refer to at Surescripts, that secondary workflow, right? Now she's stepping out of there. She's having conversations with the pharmacist. She's calling the doctor's office back. She's talking to the front office staff there, trying to re-engage the physician, usually getting to a nurse or a physician assistant. Ultimately ends up talking to the payer, the PBM, some of the folks there trying to coordinate care. These are the types of things that go on behind the scenes that make the healthcare system be branded in a way that we've got extraordinary complexity. And the consumers, quite frankly, are saying, you know, that's about enough of that. So let's chat a little bit about that. How do you guys see this playing out, and do you see similar vignettes that can be dealt with here? Steve, why don't we start with you here?
Yeah, so, you know, if you think about it, and many of us in this room are responsible for it, we have created a really horrible experience for patients, right? You go to see your doctor, I'm making love to a keyboard, I don't make eye contact with the patient. And that keyboard, the whole system was designed for billing, not for taking care of patients. And so I'm making love to this keyboard, I don't make eye contact with the patient. When I finally get off the stool to talk to the patient, I have so little time, I examine them through their clothes. And the patient is looking at this and they're saying, why am I paying all this money and why did I have to wait so long for this appointment if this is the experience I'm gonna have? And it's the people in this room, we have all created this. The system is giving us the results of this that we have created. And so we have got to change this, which means, and we keep hearing in other industries how they have liberalized the use of data. We have got to take that same data, we have got to be able to give people a better experience, we got to give people access to that data. And when I mean people, I'm talking about the patient should have access to that data so they know what they want when they go to see the physician, but also the physician needs to have this data. We have got to totally re-engineer this experience so that you actually have that human touch again, and that human touch doesn't even have to be in person. You know, when you look at the satisfaction levels of people who actually are visiting their physician virtually, especially for those patients that have behavioral health issues, it's extraordinary. And so we can make a better system, Tom. And so much of what you do at Surescripts is you guys design so that doctors are getting in their workflow, in real time, the information they need. And when that happens, all of a sudden you can totally change that experience. And so that's where we have to move to. And it's really the people who are building these systems that are at this conference that are responsible for that. And so we have got to work collaboratively across the spectrum of healthcare to make sure that it happens.
Thanks, Steve. Troy?
I don't have much to add to it. See, I think Steve did a good job there.
So we have two takeaways, okay? Progressively evil, making love to a keyboard. Make sure that those, you know, those are something that certainly will make it into my vernacular. So if you're here from Surescripts, we certainly want to make sure that that we credit Dr. Miller on this. You know, as we look at this, you know, and Steve, you certainly highlighted it. You know, it's a situation where we all collectively have an obligation here to do this. As we're working to change the tone and the tenor there, you know, how do we help patients navigate the information that's being presented to them in a way that they can actually consume it? I mean, if we look at what went on with the media transformation 20 years ago, one of the challenges was that it became difficult to understand what news was news and what news was, quite frankly, just somebody blogging on the internet that got picked up, that wasn't sourced, et cetera. How do we make sure that this is information that can be trusted and accurate and actionable? Troy, what do you think there?
Well, I was thinking while Steve was talking and didn't know exactly sort of how to raise it, but it continues to sort of come up, which is that, you know, sort of when everybody who's out there sort of buying something, they're completely empowered. You know, they know what it is, they know what it's going to cost, and they're making their own decision. They're a consumer, right? And so, you know, we tend in our company to sort of use that notion of consumer as being kind of empowered. You know, that you've got the information that you need and that you're making the right choices. A lot of times when you're a patient, and this might not be in your PCP visit, but it's certainly true, like if you're in the operating room about ready to get operated on, you're relatively sort of passive. You put your sort of trust in other people's hands, and you don't feel as though you're necessarily sort of making the decision. So I think what you want to do is get more of that consumer frame of mind into the healthcare system. And That's certainly what a lot of others are promising, big tech companies and things like that, that there would be that sort of sense of consumerism. But in order to do that, then there's a responsibility. When you're buying something online, you understand what it is you're buying. You understand you're responsible for the costs associated with that. And there's also, you've done the investigation to make sure it's going to be something that's good. It's not that easy in healthcare, but I think, sort of consumerism and empowerment sort of is a two-way street. Now, the part that's on us is to provide people with the information that they need.
Yep.
And, unfortunately, that's not just information about sort of what's going to happen. It's also information about how high a quality it is that's going to happen. And then secondly, what it's going to cost. What it's going to cost you, what it's going to cost the insurer, whoever the third party is standing above this. And that third party is not necessarily sort of helping make you a consumer. They're probably leading you in the direction of sort of not being a consumer. So it's important to provide all that information. And I think, as we'll talk about later, as we get more into transparency with regard to costs associated with prescriptions, for example, it's going to be the responsibility of the individual to understand that information. And it's going to be their expectation that they're going to get that from the provider. So it's really all three, the individual patient / consumer, the provider, and the payers all on the same page with regard to providing the kind of information that people need in order to assume this consumer stance.
Yep. Nope, that alignment will certainly be key. Steve?
Well, Tommy, it's actually a yin and yang. Most of you have actually experienced getting too much data. When you think about the number of alerts and the alert fatigue you got in the early systems, it was just too much data, and it wasn't the data you actually wanted. It wasn't the actionable data. Same thing is true for patients. I'll give you a great example. We did this pilot where we said, let's tell docs when the patient picks up their prescription or if the patient doesn't pick up the prescription. Well, that sounded great. The doc said, oh yeah, I'd really like to know if my patient's picked up the prescription. But then what happens is you have a diabetic and they don't pick up the prescription. And the doc is now thinking, oh my God, my liability. If the person walks in with DKA tonight and they didn't pick up the prescription and my office didn't hunt them down, am I liable? And so what we have to do is we actually have to have curated information that's for all the people that use our systems, the patients and the physicians and the other healthcare providers. And so we really have to do something we didn't do in the early years. We have to really look at human factors. And we got to understand what are the things that people want in their workflow that really works for them, that actually makes this better experience. And that includes for patients and for physicians. So to Troy's point, patients really want to know what are the choice of medications they have to treat their condition and what are the different prices, and not just the price of the medication, but even where I go to pick it up. Is it cheaper at Mayo? Is it cheaper at a CVS? Is it cheaper at a Walgreens? And so giving them the information they need, the way they want it delivered, in the right time is crucial. And those things are really, really hard. And that's what many of your companies are doing, is trying to figure out those human factors to make sure the system works. Because historically, we did not make the systems for anything but essentially billing efficiency.
And when we have a system as complex as our healthcare system, what are some of the risks around misalignment that occurs here, right? When you've got information flowing that way, you've got, as you said, the payer, the prescriber, and the patient need to be aligned. The pharmacist needs to be aligned. What are some of the risks that occur with misalignment, and how do we take steps to make sure that doesn't necessarily happen? Steve, any insights there?
Yeah, so the best example is something I already mentioned, and that was alert fatigue. We were totally misaligned. We sent doctors every single counterindication for every drug combination. Well, if you look at the PDR, there's a lot of drug counterindications. And so doctors just turned those things off. They said, okay, I'm getting alert fatigue. I'm going to turn off all the alerts. Well, now you're actually creating a dangerous situation, because now when you do have a crucial alert, it's not coming through either. And so we have got to align it so that we're actually giving the physicians the information that they need at the time they need it. We need to give patients the information they desire at the time they desire it. And so there are all sorts of exciting breakthroughs that are coming. Some of them to extremes where we have, for instance, we have a patent where we've geofenced every physician's office. If you turn on your locator, we can actually send you a message right as you're walking into your physician's office that says, now that you're at your internist's office, here's the specific questions you need to ask. Can I move to this generic? Can I move to this different pharmacy? things that will actually save them money, improve their health, and delight them with the experience. And so I think the warning is we've got to make sure that we don't overload people, but we're giving them the stuff at the time they want it, in the form they want it.
Great. Troy, anything?
Well, I'm struck by the DUR example, and I was also, the name of the program was View from the Top, but I always feel like my view is like I'm right in the middle. You have these little tasks that you're attempting to get done, and the tremendous bureaucracy associated with these big corporations makes it difficult to do so, but just how complex our system is. So on the DUR front, the average CVS pharmacist gets something like 450 DUR messages in a shift. So you know that, there was an academic paper done by some friends of Steve and mine almost a decade ago suggesting that the DURs that are in the electronic medical record system should decrease from about 300 down to about 20. But make sure you do each of those 20 rather than ignoring the sort of 300 that are coming through. But just to sort of show the complexity, when I at Caremark have a network with Walgreens, or when Steve at ESI has a network with CVS, they send all of their DURs. So their insurer requires that they run all the DURs and send it to us. So like a big place where we want to eliminate DURs is just eliminate the third-party DURs that are coming through. So we just run the ones that are at CVS retail. Only problem is that some of the ESI customers are going to go to several different pharmacies, and there could be drug-drug interactions that we wouldn't know about. So how do we sort of figure out which ones are the ones that are related to the fact that there are numerous pharmacies involved? Now, all of this is solvable, but all of you all are here because you're interested in healthcare information technology, right? So just, when you start thinking about exactly sort of how I turn those off, increasingly, like I'm sure ESI and Cigna, we turn to artificial intelligence for this. And there's very interesting sort of approaches that we're beginning to get a look at and can take. But, when you think about that particular set of problems, Steve raised it with the DUR, you realize how complex the system is when you layer in all these sort of various good impulses into a situation that turns out to be bad. So I think it's a great example of kind of the problems with our healthcare system that are related to health information technology.
And I think for the audience, I mean, if you listen to this, we all obviously agree that the consumer, the patient, the member needs to be front and center in all of this. However, we also have to make sure that we understand what we are inflicting upon them and their ability to consume, no matter how well it's packaged. The volume of information that could float their way is just really questionable. We've got to find a way as a system to come together on this, to Troy's point, and make sure that while we're maintaining that alignment between the people bearing the risk, the people delivering the care, and the patients themselves, that we do it in such a way that everybody is able to act on the information. That's one of the key things that Surescripts has always believed, that the issue is actionable intelligence, not just more data being thrown at the problem. You've got to be able to act on what we're trying to do here. So let's move on. Let's move from the consumer side of the house and start to talk a little bit more specifically now about the issue of price transparency itself. This is something that we've been pursuing as an industry for a long time. In fact, Surescripts first looked at this type of solution sometime around 2010. But at that point in time, quite frankly, the industry wasn't ready. The infrastructure wasn't quite there. The EHRs were trying to do other things at that point. The payer infrastructures weren't quite ready for this type of thing. The delivery wouldn't have been as reliable. And so as a result, it got set aside, which I think was appropriate. But in the meantime, the challenges faced in the system just continued to grow. If we look at the amount of money spent, we're talking about $425 billion on prescription drugs in 2015. We're talking about that number approaching $600 million a few years from now. The numbers just continue to get bigger. The growth rate in cost is unfortunately just not sustainable. So from an audience standpoint, we talked about my family member's experience. How many of you have had a similar situation where a family member, a friend, a loved one went through a situation where they were prescribed a drug, got to the pharmacy and went, oh boy, not at that copay. That's just not happening. Anybody? Yeah, and that's really, I think, think the biggest change that we see over the course of the last few years, certainly during my 5 years at Surescripts, is there's just increased and heightened sensitivity to all of this. And again, some of it comes down to the consumerism angles. I think the other thing we have to remember is that we're going to talk about the amount of savings on a per prescription basis, and that's a significant number, and we need to have that discussion. We also need to remember that adherence number that I talked about earlier. The impact on the healthcare system of adherence and the challenges of adherence is quite large, and it's something that we need to look at and take seriously. And so our combination at Surescripts of real-time prescription benefits, electronic prior authorization, e-prescribing, all of these are tools that are designed to come together to not only get to a better outcome economically and a better outcome from a clinical standpoint, but to do so in a way that the overall experience is something that is better for the consumer than it has been historically. I'll share some other numbers with the audience here. We've kept a close eye as we've rolled out this product on the nature of the savings, and I'm sure Troy and Steve will share some of their own organization's experiences. But we've seen experiences where individual patients have generated savings on scripts as high as $8,000 because of use of a different drug that was on formulary. So a change in the to an alternative has done a huge amount to help there. We also see that about 28% of the time when a prescriber is shown an alternative that does not require a prior authorization, they will move from one that does require prior authorization to the one that doesn't. The ultimate savings there sits at around 158,000 person hours per month of administrative overhead that is currently set up in the system. These are the types of numbers that we're chasing. So with that, guys, let's talk a little bit about, from the Cigna perspective, from the CVS perspective, why is this type of price transparency? Why is real-time prescription benefit important to your organization? Troy, you want to start this one off?
Well, yeah, it's odd to have two executives from PBMs sort of talking about transparency, because it's not an industry that's necessarily sort of known for transparency. At least I don't know about Steve, but at our place, I think there's like 4 or 5 people who actually understand everything that goes on when a drug goes from a manufacturer to a patient. But sort of having said that, transparency is just good business for us from the point of view of making sure the patient gets on the medication and stays on the medication. That's one thing about these vertical integrations. We don't see any consolidation. We see vertical integration as a good thing. But both with regard to Caremark and Aetna and Cigna and ESI, what we've always said at the PBMs is that the most important thing is to our customers is what the overall cost of healthcare is, not necessarily sort of cost of the medications. Now with the space and population health management that you have with the insurance company, it's sort of evidently true that that's the case. And so that means that you have to make sure people are taking the medications in order to get the best results from them. And generic medications are the most cost-effective intervention that's available in healthcare. So, and in order to do that, transparency is going to help. I think that's the most important point, and one that you raise, is that insofar as we let people know that there's a prior authorization on one drug but not on another drug, or insofar as we demonstrate that a medication is going to cost somebody a lot less out of pocket than another medication, that means the patient's going to take that medication. And if they take that medication, lower overall healthcare costs. So, from our point of view, being able to sort of provide information, whether it's to the individual provider on their electronic medical record, or to the individual consumer on their smartphone, or to the retail pharmacy, so the retail pharmacist can help with that. To provide that kind of information that's coming directly off the adjudication engines is a really important thing, and something that we just see sort of as good business overall. And I think with regard to big corporations like this, you've got to sort of follow kind of what's in their interest and what's good business for them. And so our interests are exactly aligned with this kind of transparency in prescribing.
Terrific, thanks. Steve?
Yeah, so when you can provide transparency to both the provider and the patient, you can actually get phenomenal outcomes. So if you think about what Tom was talking about with real-time benefit check, When a doctor knows which is the covered product and what the price of that product is, and they can share it with their patient, they can make the right decision the first time. And so it is phenomenal when you see the cost savings. And so when you give real-time benefit check to doctors, they actually will change from their original prescription to an alternative prescription 28% of the time, and it's not to an inferior product. It's a product that's just as good. And so the patient gets a really great therapy at a much reduced cost. And so real-time benefit check can actually drive down costs dramatically, and it's behind the scenes cost. It's keeping patients on their formulary. As a physician, you know, I have these companies come to me, I have hundreds of different formularies. I can't remember each of these formularies. The computer can. The difference between my memory and the computer's memory is pretty dramatic. And so the computer letting me know what formulary you're on, what the preferred product is, because if you think about it, let's take statins. You know, all the statins work pretty much the same way. If I knew which the preferred statin is for you, I'm going to prescribe that. You're going to be happy. You're going to have a less expensive price. You're going to be able to be more adherent. To your point, Tom, if we did this really well with real-time benefit and electronic prior authorization, and we could drive up adherence, as you pointed out, is worth over $300 billion in savings. If you could get patients on the preferred product that their insurance company covered, that's actually worth another $60 billion. And then if I can drive patients to the cheapest channel to get their drug, either mail order pharmacy, or if it's CVS that's in the network, or Walgreens that's in the network, that's worth almost another $40 billion. That's $400 billion in savings with better health outcomes. And so having the right information for both the consumer and the provider can actually give us those type of savings. And so real-time benefit checks is a great example of it. Electronic prior authorization, same thing. When we have electronic prior authorization, so now about 80% of our doctors are empowered with electronic prior authorization through Surescripts, what we find is that they reduce the time that they have to deal with that prescription by almost 11-fold. They often are getting a result. That is, they're getting a clearance within 2 minutes. And so as a practicing physician, what a time saving. So we're not even counting the savings of just making offices more efficient. We're just talking about the savings direct to the consumer. But the savings for the providers is also extraordinary. And so when we talk about how do we simplify the system, how do we get rid of fragmentation, how do we use data intelligently, real-time benefit check and electronic prior authorization are phenomenal steps forward. And really, you're just seeing the tip of the iceberg. We have, if you think about the literally almost 1 million providers that are out there, we have about 100,000 that are using these tools on a daily basis. Now, importantly, they're the right 100,000. They're often the high prescribers. But if we can migrate this to where every provider is doing this, it would really take friction out of the system. I think patients would be much happier with the products they're getting, and the providers would be thrilled because you'd be taking all that rework out of their offices.
And just to add, I don't think either Steve or I sort of feel in any way kind of badly about this idea that, you know, it's not this medication that the doctor initially chose, but it's a different medication. Because in Medicare by regulation and in most of our commercial contracts, we're required to sort of follow an independent pharmacy and therapeutic committee's recommendations around sort of what's on the formulary, and what we can do prior authorization on, not do prior authorization on. So we have an independent group of physicians that's basically defining the standard of care for us, and then we have to adhere to that. So it's not like we're making a decision that's sort of based on the way that Caremark or Express Scripts would sort of see things. We're making it based on sort of what is the standard of care. So it's very much an evidence-based format that we're using. And I think that's a point we have to emphasize to physicians more and more, I think.
One of the things that we learned at Surescripts is adoption of these types of tools tend to take longer than people would like. Just to remind everybody, electronic prescribing is pretty much everywhere today, but it took 10 years to get to 50% market penetration on electronic prescribing. As you look at this with your physician hat on, you know, what would a detracting physician say? Where do you think the challenges will be for those that are kind of at the tail of the adoption here? What are they going to look at and have concerns about?
Yeah, so there's a couple of different groups that actually resist this, right? And so there are certain people in practices, especially if you're in a low volume practice and you just don't want to make the investment to buy the tools. And so there's always been this barrier to adoption because there was an investment you had to make to buy a system. What's really extraordinary is many of you have actually created tools that are free. You can actually, as a physician, register with many of your companies and actually do free e-prescribing. You have almost no investment at all except yourself, your smartphone. And essentially 100% of docs have smartphones. And so that barrier is coming down. The second is this, and that is one of the biggest problems I see is we have an enormous number of legacy systems out there. I had always thought that you would have the market collapse to where you'd have about a half dozen or a dozen really capable EMRs out there. There are still over 300 EMRs out there. And once you've invested in that EMR, you actually never want to let go of the one you've invested in. You have a sunk capital cost. And so the question is, how are we going to get all these EMRs? Because we, through Surescripts, can actually display this data to 100% of providers today. The trouble is that their EMRs have to do things that display the information. And unless they do the programming to display the information, it's lost. And so it's a lost opportunity. So I look at it as the big barriers. The cost barrier is coming down because you can now do these things through smartphones. But the other big barrier that's still out there, though, is all the legacy systems and their reluctance to actually do the reprogramming to be able to take advantage of the data. We have to have transparency. It actually works in our business models. It works in your business models. It drives better behavior by patients and providers. And so transparency is crucial, but you can't have transparency if your tools aren't programmed to display it.
Troy?
Yeah, I think Steve's right in everything he says, and I see sort of three sort of major kind of motivations getting physicians to participate more. It is easy. We have a big electronic medical record, one of the big electronic medical records that we use in all of our disease management and retail clinics, and increasingly sort of with the pharmacy, so we have a good view into it. It's easy to turn stuff off, so if the doc's feeling like they're getting hassled, and docs are feeling like the average doctor's like, I don't want any more information coming from this machine, I've had enough, no mas. But I think there's three things that sort of lead them. One is that they have to recognize the way that the healthcare system is being financed now, that people increasingly have a lot of out-of-pocket payment. In the first place, it hits the pharmacy. So they don't want to prescribe a medication and then have the patient not take it. Most physicians are extraordinarily committed to the individual welfare of their patients, and over time, they understand this, and so they understand that it's better to go. The second thing is, as Steve said, like something like electronic prior authorization, it reduces administrative costs for us, it reduces administrative costs for them, and reduces hassle factor enormously. So the AMA, very eager to sort of, what can we do about prior authorization? Our answer is, we can get more people sort of on electronic prior authorization, more people on sort of a real-time benefit information. But then I think the third thing and most important is that it's really hard to sort of look at the finance, the aging of the population, the financing of the healthcare system, and the way the federal government is kind of playing out its finances right now to not believe that there's not going to have to be a major move towards risk amongst individual providers. I mean, people talk a lot about risk today, but the average big medical center, where they got 2 or 3% of their total dollars are sort of at risk for quality or cost. But I think increasingly they're going to have to move to population health management risk, and as they do that, then that aligns with the impulse to basically get the person on the lowest cost medication and make sure that it's the right medication for that individual, and then that the individual is going to take that medication. So, it has been, these sort of 5 and 10 year sort of adoption frameworks is something that in a relatively short professional career you have to put up with, but I'm fairly certain by 2030 that when we get to the other end of the 20s that there's going to be a substantial shift towards risk, and it's going to motivate physicians to want to take advantage of these tools.
I think that alignment point, you've raised that a couple of times, is vital, right? The better aligned everybody is,
yes,
the easier this gets for all of us. I asked the question about the kind of the tail of the adoption curve. We're actually seeing this individual product be one of our most quickly adopted products ever. We saw 1,300% increase to 110,000 physicians in its first year in the market. In January of last year, we did about 300,000 such such transactions. We ended December over 6 million transactions. So we're seeing really rapid uptake here. And I think part of this is, as you put it, Troy, I think there is a philosophical alignment. It may not be contracted that way yet. The dollars may not be flowing that way, but philosophically, people are getting ready for that new state of healthcare in the future. And I think a tool like this can certainly help make a difference. You also mentioned the government side of this. The government put out a proposed rule not long ago about this. Curious, Troy, how does CVS view that rule and similar rules to help spur adoption and keep industry focused on these types of challenges?
Well, the general impulse I see coming out of the government is that they're concerned that information is being sort of harbored or held tight by individuals, individual groups that seem to think that they have an advantage by sort of holding on to it tight. And I think, I think they're right to be concerned about that. I don't know exactly how much of that is conscious as opposed to sort of unconscious behavior on the part of people who have healthcare information, at least from my point of view, and I think that this is also our corporate point of view, although I'm not always sure about the alignment there, is that that information should flow very freely. That our ability, and Steve was talking about this, our ability to increasingly sort of understand ways in which we need to intervene on individuals is dependent on having as much information about them as possible. Now, the privacy laws are very good, and the privacy laws are very important. We have to follow all the privacy laws associated with that. But if you think that what you're doing, and as insurers and on the PBM side, and certainly sort of in the retail pharmacies, you're aligned with the welfare regard that the individual physician has, and as long as you're using the information to try to improve those people's health, then you should be in reasonable shape with regard to the privacy laws. So I think we're very much in favor of allowing sort of full information that we have flow to others who need it, and expecting the sort of reciprocity associated with that.
So Steve, from your standpoint, Cigna, how did you guys view that rule and some of the other government activity?
Yeah, so there's, as you know, with all these things, there's pros and cons. We have got to be totally fixated on taking care of patients. Patients have got to be the center of our universe, and it can't be our individual companies, which means we have got to liberalize the data so that those patients can not only access it themselves, but the people they trust to access it, the providers they choose, actually have full access to that data. And so I think CMS and others are really trying to nudge us in that direction. But we also have to be very cognizant of the fact that people really like their privacy. And we have got to really make sure that we have firewalls that can withstand anything, that the patient's privacy is respected. And so if we built the system around the patient, we'll get to the right spot every time. And so it's not about protecting the corporations, it's about protecting the patients. And so we feel very strong that we need to liberalize the patient's access to their own data, and we need to liberalize the approach for the providers they choose to access that data. And so I think that is all possible. It's not easy, but it's very doable. And I think this administration, actually the leadership both at the FDA, CMS, both really get that, and they're trying to nudge the marketplace towards it.
Great, that's helpful. So we talked about the liberalization of data. One of the things that I think some in the market were surprised at was the willingness of firms like yours to share via the real-time prescription benefit what is in effect your formulary, right? Which is in effect, a key part of the secret sauce that helps everybody optimize the outcomes and contain the costs, et cetera. Was that a challenge philosophically within the business, or was that something that came naturally and you just saw that as an outgrowth of where we're all headed?
No, I don't think that was a challenge at all, really. I mean, we negotiate our formulary. Steve and the other PBMs negotiate their formulary. It's public information at that point, that you want the doctors to sort of know what's on formulary and what's not. So. And with regard to the sort of out-of-pocket payment parts of it, that's a matter of sort of being able to understand the information from the insurer about exactly sort of what the nature of the benefit plan is. But again, nothing sort of really, I would feel like there's nothing of any value from a secretive approach to that. So I don't think that's ever really come up for us that there would be concern in that regard.
No, in fact, we publicly post our formularies, but let me make it clear for especially the non-physicians in the audience. You wonder why, if everyone's looking at the same data, why should different companies have different drug lists, right? Shouldn't they all get to the same conclusion? The reality is there's 15% of drugs that are in the marketplace that are truly unique. They have unique mechanisms of actions and unique outcomes. Every one of us have those same 15% on our formularies. 85% of drugs, though, have what are called options. That is, you have 8 different statins on the marketplace. They all work the same. And so the economics that CVS gets on a statin may be different than the economics Cigna gets on those statins. And so that's where you get the difference. And so the formularies are equivalent in their efficacy. They take great care of patients, but they may vary in the choice of those drugs that have some optionality. And so the reality is physicians and patients can't remember what all those choices are. The beauty of computers is they have great memories. And so the reality is that if we actually make it public, if we have transparency, and if we make it really easy for the patient and the provider to access that data, we're all going to get to better outcomes at a lower cost. And that's the secret behind this. And so that's why when Troy says it's really easy to put this out there, it's really easy for us to put this out there, because if it's not out there, you as a provider can't make the right actions. And so it truly aligns. It gets back to your point earlier. It's true alignment in the marketplace to get patients lower costs and better outcomes.
So let's jump back to that provider side. I've got some numbers here in front of me. We've got 87% of healthcare professionals believing that their patients' prescription costs are getting them is a significant or moderate challenge. Almost 80% believe it's extremely or very important that they have access to that out-of-pocket information, and 70% believe that it's important that they see the availability of lower-cost alternatives at the point of care. Have we reached the point then where there's a true demand, do you think, for the prescribers, for the pharmacists to see this information as they're interacting with the patients?
Well, let me answer for the pharmacists. The answer to that, because we have 35,000 retail pharmacists, the answer is absolutely. So, we're making this information available to, that we have from Caremark, immediately sort of available to our retail pharmacists so that they can understand and deal with it. We want to get that information out to the other major chains that we deal with, and they're in process of trying to sort of think that through. And I know that our team at CVS Retail has had conversations with Express Scripts about getting the same kind of information. So the pharmacists really feel, pharmacists feel stricken when they've got a patient who's there and shows up and not able to afford their medications. This is going to increasingly sort of occur. About 55% of people who would be considered middle class in this country don't have enough savings to pay for the cost of their deductible. So that's a very striking statistic, and it means that more and more people are sort of going to be in this kind of situation, and the retail pharmacists want to address that.
Yeah, so here's part of the complexity, and Troy brings this up. We actually have multiple health systems functioning simultaneously, right? We have the commercial market, we have Medicare, we have Medicaid. We actually have more markets than that, but the rules of the game are different for each of those and how they get reimbursed. If we can't give the pharmacists the information they need to be empowered to take care of each of those different types of patients, we're underserving the patients. And so giving both the provider community, so physician providers and pharmacy providers, that information empowers them to make the right decision and help guide people. Now almost 50% of people have high deductible health plans. High deductible health plans are much more complicated than the old days when we had just fixed tiers of $10, $20, $40. And so if we're going to use these new tools that are coming to the marketplace, we have got to empower both the patient and the providers to have this information. If you do it, you can save enormous amounts of money because you can guide people to the right choice, and you can do it with an equally good product. We got to keep emphasizing the fact that you got to put clinical first. The patient has got to get the right product. But that right product is often optional about which one it is, but the cost is dramatically different between the two. I'll give you a great example. I had a family member that was put on Gleevec. Gleevec was $125,000, but the generic had come to the marketplace. The generic was dramatically different. It made tens of thousands of dollars difference getting them to the generic. Having that information that the generic's available, that the patient was still on a brand, and switching them to the generic, that saved that individual literally tens of thousands of dollars. And pharmacists and physicians and others have the opportunity to do this each and every day if they had the knowledge, if they have the data in front of them.
Yeah, and I would just add to that, and I think Steve recognizes as well, is that, you know, sort of when you think about the 3 places we can go, we can make this information available. And, you know, even with very complicated high deductible plans, we hit the accumulator. So everything's happening in microseconds to get the right information there. But, you know, you can give that to the and the number of you are big shoppers. It's going to help with a number of you, you know, who are going to say, like, tell the doctor, actually, that medication is very expensive, but I see I've got other alternatives here that seem to be the same thing. Can I get one of those? Okay, it's still the minority of patients who are going to do that. And the pharmacist can help, but the pharmacist is downstream of all this. And so there's a lot of sort of administrative costs associated with that for everybody once the pharmacist is trying to sort of deal with it. So that's why we're at HIMSS, you know, we're talking about electronic medical records. You know, that's why it's so important to have this in the EMR. And, you know, the docs are, unfortunately, sort of looking at that EMR during the patient visit. That's the best and most appropriate time to do this. So what we really need are sort of allies amongst physicians and medical groups to be able to sort of transmit this information, because that's when it's sort of most efficient.
Yeah, Tom, I want to add one other thing, though. We also are overusing medications. The best example is opioids. And these EMRs and these electronic systems and having transparency and seeing the number of docs that are prescribing these things and the total number of doses the patient's getting is really crucial to actually driving down misappropriate opioid use. But let's say the same thing about antibiotics. We way overuse antibiotics. And so having the information, knowing what the patient's been prescribed elsewhere is really crucial. And so it's not just driving the appropriate use of other drugs, it's decreasing to appropriate levels certain drugs. And so I'm really hopeful these systems can make a huge difference.
We've only got a minute or two left, but if we have any questions from the audience, this would be your time. Any questions for Dr. Miller, Dr. Brenner? Brennan, we've got the microphone set up there if someone would like to come up.
Yeah. Hi, thank you very much. And I think we started to touch on this a little bit at the end here, and I agree that the retail pharmacist trying to address a cost question at the very end is so far downstream. And we've talked about patients being at the center of things and consumerism. Could you talk a little bit about how you are educating your patients and your members on high deductible plans or even the deductible in Part D? Because if people understood their benefit designs, maybe they could make better decisions, because I'm sure if you ran a benefits check claim in this room, you would get probably, you know, 75% unique returns back on that in terms of the patient out of pocket. So how do we help empower patients on the education of their benefit designs to make those better decisions, so that we also alleviate maybe some of the pressure on the physician to maybe then become almost an insurance broker to kind of educate them and sell them on the benefits of it? So I think that proliferation of patient engagement would also maybe alleviate some of the pressure in terms of the high deductible plans and some of the other systemic issues and confusion that patients have around price. So thank you.
Yeah. So I can go quick. You know, we've actually, and Troy's company has done the same thing. We have created incredible apps for our company where patients actually have access to this information. They download the app, they can see exactly what it's going to cost them for each drug, so what their choices are, what their choices of pharmacy are. And so we actually don't try to make them educated as how these benefit designs work. We just tell them in real time, what's it going to cost you on this fill? What's the right choice for you and what the right location to pick them up in. So to make it really simple, I think the tools that we're creating for patients are really trying to give them that visibility and that education.
And we got now, you know, old PBM guys, you know, we got insurance companies now. So, you know, and on the insurer side, I'd say Medicare Dan is a good example. You know, I think, you know, we get rated by the federal government in terms of the type of information we provide. I think that's a market that at least looks to me like it works pretty well, that it does manage to change, you know, people into reasonable sort of consumers. And then we work a lot with our clients, you know, for, you know, when they're providing information, when employer-sponsored insurance for their employees, to make sure that information is getting out there. I don't think it's always been the best information, but I know almost all of the major insurers today are trying to use a mix of better technology and behavioral economics to try to get people to really understand what it means for their for what their benefits really mean for them.
Well, folks, I hate to bring this to a close, but I've got a flashing red light here that tells me I need to. We want to thank everybody in the audience for coming out this morning, and certainly want to thank Dr. Brennan, Dr. Miller for spending time with us. Enjoy the rest of HIMSS.